let's set the stage. We're looking at a 55-year-old woman. She has a 2-year history of severe dry eyes and a very dry mouth.
The classic Sika symptoms.
Exactly. And on top of that, profound fatigue and these diffuse joint pains or arthralgias.
Okay.
Her blood work is very revealing. A positive ANA test, high titer, with a speckled pattern. And this is key. She's positive for anti-RASA antibodies.
Right. So the picture is already coming into focus.
It is. So based on all that, here's the question. Which of the following is the most specific objective test to confirm a diagnosis of primary Sjögren syndrome?
Okay.
Is it A, a Schirmer's test showing reduced tear production, B, a positive anti-SSB antibody test, C, a labial minor salivary gland biopsy demonstrating focal lymphocytic celadonitis, D, the presence of subjective xerostomia reported by the patient, or E, an unstimulated whole salivary flow rate of less than 0.1 ml per minute?
It's a great question because the clinical picture is already so strongly suggestive of Sjögren.
It really is.
You have the dryness, what we call keratoconjunctivitis sicca, and xerostomia, and it's backed up by that really strong serology. The anti-Rho antibody is a hallmark.
Right.
But, to get from a strong suspicion to a concrete confirmed diagnosis, research has shown we need objective proof of an autoimmune attack on the glands.
So you need to see the evidence.
You need to see it. And that's why the correct answer, the most specific test, is C, the labial minor salivary gland biopsy.
Okay, so that brings up a really important point about specificity. Why is that biopsy so much better than, say, the Schirmer's test or the salivary flow test? I mean, they also measure dryness, right?
They do, and that's the key distinction. It's about cause versus effect.
Oh.
A low Schirmer's score or reduced salivary flow, they confirm glandular hypofunction. The glands aren't working properly, but they don't tell you why. That dryness could easily be from aging or, common medications like antidepressants or even just dehydration.
So they're not specific to the autoimmune cause.
Exactly. The biopsy, on the other hand, is the histopathologic gold standard. It gives us the tissue, the proof. It confirms the cause of the dryness is that autoimmune attack.
So we're not just confirming the dryness, we're confirming the actual inflammation. What are we looking for under the microscope with a term like focal lymphocytic celadonitis?
Well, it's fascinating how precise this is. We are literally looking for dense clumps of at least 50 lymphocytes.
50, wow.
50 immune cells, all packed together in a little ball we call a focus. We then count how many of these foci appear in a 4 square millimeter area of tissue.
And there's a specific number you need to hit.
Yes. A focus score of 1 or more is a key objective criterion. It's non-negotiable, and it's used in classification systems all over the world. It's direct proof of the autoimmune infiltration.
That sounds aggressive, that kind of structural damage. So beyond just getting the diagnosis, what does this level of chronic inflammation mean for the patient long-term?
This is where we have to connect it to the bigger picture. The intense, persistent B-cell activation in Sjögren's carries a very serious risk.
Which is?
A significantly increased chance of developing B-cell lymphoma. This is a major, major clinical concern.
And is there a specific type of lymphoma you're most concerned about? And what are the red flags we should all be watching for?
It's most often what's called mucosa-associated lymphoid tissue, or MALT lymphoma. For you, the listener, the key warning signs would be any persistent swelling of the parotid glands, skin lesions like purpura, swollen lymph nodes, or something called cryoglobulinemia in the blood tests.
So to pull this all together for our deep dive, confirming Sjögren syndrome really hinges on objective evidence. And while functional tests can tell you a patient is dry, it's the minor salivary gland biopsy that provides that rock-solid specific tissue standard. It confirms the why, the autoimmune process behind it all.
Absolutely. And that's so crucial because managing this isn't just about eye drops. It often means using systemic agents like hydroxychloroquine, and it means constant vigilance for that lymphoma risk. So thinking about that, what stands out to you as the most critical step in minimizing that long-term systemic complication?